So our PICO question was, are patients of ischemic strokes who receive TPA more likely to recover from serious stroke-related complications compared to patients of ischemic strokes who did not receive TPA? And then just some statistics in the US about strokes are that about 795,000 people each year have a stroke, and strokes are the leading cause of serious long-term disabilities, and it's the third leading cause of death in the US, with more than 140,000 people die each year from them. And then, so the relevance of our PICO question is that as nurses, we want to make sure our patients receive the best treatment possible. And since we know the evidence-based research on the long-term benefits of the treatment options, then we can be better advocates for our patients.
Our first article talked about door-to-needle time of TPA administration. It was a systematic review that found that the benefits of TPA in acute ischemic strokes are extremely time-dependent. All results were significant with a p-value of less than 0.001%. 4 of the outcomes that were measured by this article had the following results. Mortality decreased by 1.5%, intracranial hemorrhage decreased by 1%, ambulatory status at discharge was increased, and discharge to home increased by 5%. Overall, TPA reduced long-term disability as long as it had an early administration. Administration that was recommended was within 60 minutes.
This is a randomized clinical trial that found that early TPA treatment was associated with reduced complications and better outcomes. All results are significant with a p-value less than 0.001. The 4 outcomes measured had the following results. Among 58,353 patients, 9% resulted in in-hospital deaths, 5% had intracranial hemorrhage, 33% achieved independent ambulation at hospital discharge, 39% were discharged to home, and the faster the onset to treatment time, the better the outcomes. These findings support intensive efforts to accelerate hospital presentation and thrombolytic treatment in patients with a stroke. In conclusion, IV TPA is a treatment of proven benefit for select patients with acute ischemic stroke up to 4.5 hours after onset.
This article is an open clinical trial that focused on results of patients who received endovascular treatment after an acute stroke and patients who received IV TPA after an acute stroke. Patients studied were between the ages of 18 and 80, had no intracranial hemorrhage, and the onset of stroke symptoms were clear and defined. They were separated randomly into 2 groups, the IV TPA group and the endovascular treatment group. Their neurostatus was found using the National Institute of Health Stroke Scale as a baseline. They were reevaluated at 7 days post-stroke and again at 90 days via phone interview to evaluate the patient's condition and ability to perform ADLs. The outcomes were that 362 patients were studied, 181 in each group. 55 of the 181 in the endovascular treatment group survived without disability, which was 30.4%. 63 of the 181 IV TPA group patients survived without disability at 34.8%. This was 4.4% higher than the endovascular treatment group. There was no statistical significance between the results of each group.
My article involved a retrospective, non-randomized observational study comparing the outcomes of acute ischemic stroke patients who are 80 years old or older after the provision of treatment. The 3 treatments provided were IV TPA, endovascular interventions with or without IV TPA, or non-thrombolytic treatments. The treatments were evaluated based on patients' initial NIHSS score versus their 7-day or discharge NIHSS scores, presence of symptomatic and asymptomatic intracerebral hemorrhage within 24 hours of treatment, favorable outcomes or ability to complete ADLs, and in-hospital mortalities. The results showed that patients who received TPA and endovascular treatment with or without TPA were more likely to have a more favorable outcome, increased improvement in NIHSS scores, and higher rates of symptomatic and asymptomatic intracranial hemorrhages compared to patients who received non-thrombolytic treatment. There is no significant difference between the groups in rates of in-hospital mortality.
Our PICO question is addressed in a national practice guideline called Antithrombotic and Thrombolytic Therapy for Ischemic Stroke. The practice guideline was developed by the American College of Chest Physicians in January of 2012. The
The evidence related to our PICO question is strong because it includes a Cochrane review with a clear recommendation, strong clinical evidence, and consistent findings across the research. The high strength level of the research means that the research is consistent and backed by evidence and therefore should be implemented in practice.
So we are at DePaul Hospital for our clinical, which is a neuro ICU step-down floor. DePaul Hospital is a level 1 comprehensive stroke center that meets the standards of the Joint Commission, and it's only one of 2 in the St. Louis area. TPA, the current practice at DePaul is that TPA is administered to patients with ischemic strokes with the last known well at less than 4.5 hours. TPA is always the first treatment option as long as the last known well is within the correct time frame and there are no other risks such as bleeding disorders or recent surgeries. As far as the current policy and procedures, upon admission to the ED when there's suspicion of a stroke, a coach stroke is called. This means that both the charge nurses from both the neuro floors meet the patient with the ED team. They're transferred immediately to CT to determine what type of stroke is happening. And then their NIH score is obtained, and a score of 1 to 4 is considered a minor stroke. As soon as it's confirmed that it's an ischemic stroke and the last known well is less than 4.5 hours, TPA is started within an hour of admission to the ED. The patient is then transferred to the neuro ICU floor, which is our floor for clinicals, and TPAs continue to be administered. So once they're on the floor, vitals and neuro checks happen every 15 minutes for the first hour, then every 30 minutes for the next hour, and then hourly after that until TPA administration is complete. The patient is then placed on bleeding precautions, and the nurse is put on a 2-to-1 ratio. As far as if DePaul's procedures match up with our evidence, the overall answer is yes, that all of our articles agree that TPA is the best treatment option as long as the criteria is met. And at DePaul, the first line of treatment is TPA. So in Article 1, DePaul's hour to treatment matches up with the article saying that as long as the patient's treated within an hour of arrival, there's better outcomes. In Article 2, DePaul agrees with it that says that the time of last known well should be less than 4.5 hours so that there is better outcomes. Article 3, it says that IV TPA is more effective than endovascular treatment, and like I already said, it's the first line of treatment, so we agree with that as well. And in Article 4, basically just sums up that any treatment with TPA, whether it be IV or endovascular, is better than no TPA.
Recommendation and implementation. Overall, the evidence is conclusive that IV TPA is the most effective treatment for an acute ischemic stroke. DePaul Hospital policy and evidence suggests that treatment with TPA should be started within 4.5 hours upon onset of symptoms and within 1 hour upon hospital arrival. TPA should be initiated in order for better outcomes for the patient after the stroke, and is best early compared to late or not at all. There is no additional evidence needed as it is clear TPA improves the outcomes and recovery of the patient. Conflicts for a patient may include a recent major surgery or even religion such as a Jehovah's Witness. Barriers for the administration of TPA can include the patient and environment. The patient can be outside of the last known well or have a contraindication, and environmental barriers may include the hospital or available equipment.
This is a patient that came in with stroke-like symptoms.
Hi, I'm Krista. I'm going to be his nurse today. I'm just going to check his name, date of birth. All right, I'm just going to do a quick neuro assessment on him.
Okay.
Can you grasp both of my hands and make a fist? Can you smile and stick out your tongue? Just checking his pupils. When did his symptoms start?
Like 2.5 hours ago.
Okay.
This patient will receive TPA because his symptoms started less than 3 hours ago and he meets the criteria. His NIH score was 18. 2 weeks later, this patient did not suffer intracranial hemorrhage, was a Cis ×1 at discharge, and sent to rehab and had the ability to perform ADLs. His NIH score at discharge was 4.
Ready to head to rehab?
Yes, ma'am.
patient also came in with stroke-like symptoms.
Hi, I'm Krista. I'm going to be his nurse today. I'm just going to do a quick neuro check. I'm going to check his name and date of birth. Alright. Sir, can you grip both my hands? Alright. Can you smile and stick out your tongue? I'm going to check your pupils. When was his last known well?
Like 6 hours ago.
This patient does not receive TPA because his last known well was roughly 6 hours prior. His NIH score was also 18. 2 weeks later, upon discharge, this patient suffered intracranial hemorrhage during his stay, is non-ambulatory, and was sent to a skilled nursing facility unable to perform ADLs. His NIH score was 16.
You ready to leave?
No.
Alright.